Surgical airways and care in adult patients. A surgical airway is best described as a result of a medical procedure, creating a new airway opening for a patient, essentially relieving an obstruction and allowing the passage of air. Surgical airways come in many forms. We will talk about them shortly. The most common indication for surgical airways are acute respiratory failure and the need for prolonged mechanical ventilation. This represents 2/3 of all cases. Upper airway obstruction, traumatic or catastrophic neurological insult requiring airway or mechanical ventilation, or both, and are used for patients that may require an airway due to an obstruction, protection from collapse, anatomical abnormality, and/or difficulty managing secretions. Moving forward with laryngectomy patients. Patients with a total laryngectomy usually require the removal of the entire voice box. With the removal of the larynx, the trachea is then brought up to the skin of the neck as a stoma, which the patient will breathe through. Having a stoma instead of a larynx means the patients will not have an air passing through their nose or their mouth. A stoma is the opening created in the neck. For this reason, a laryngectomy patient with a stoma, if requiring rescue breathing, please perform the bag mask ventilation via the stoma site using an infant-sized mask per ECU Health policy. Please remember, a patient with a total laryngectomy cannot be intubated via nose or mouth. They must be intubated via stoma. Please review the laryngectomy facts, total laryngectomy sign, and post-op pulmonary care for total laryngectomy patients video linked within this slide. You will note at ECU Health Medical Center, Eddie and Joe Allison Smith Tower for cancer care treatment, there are several patients that may have a Larry tube in place. This tube is a silicone tube designed to maintain the airway of a laryngectomy. Larry tubes are available at ECU Health. I've attached a video linked in this slide for more information. An open stoma. Some patients have a stoma but may not necessarily have a tracheostomy tube in place. Remember, a stoma is defined as a surgical opening at the neck. Patients with an open stoma could possibly be a laryngectomy patient, but that is not always the case. Do not ever assume. Some patients may have had that opening established and it continuously grew larger over time. Please always confirm with your patient, their family, or their home health care providers while discussing a surgical airway if the patient is unable to do so. Trach and stoma buttons. These devices are used to maintain the tracheostomy stoma. A button does not have a cuff. Therefore, it is limited value in cases involving risk of aspiration or during positive pressure ventilation. Examples on the market you may see here at Vidant Medical Center are the Montgomery systems, Larry Tube, Blom-Singer, and Provox systems. Please note within the slide are educational links for you to review each system and be informed properly. So what do you do when your patient has a surgical airway? First, notify respiratory of the patient's arrival. The Respiratory Care Department at ECU Health should be aware of every surgical airway patient, and a respiratory therapist will assess the patient every 6 hours. The Respiratory Care Department is responsible for providing an emergency airway kit that must be available with the patient at all times. That emergency airway kit includes a number 6 endotracheal tube and a 14 French suction catheter. If the patient is a laryngectomy, an infant mask will be provided along with laryngectomy signage. Remember, nursing and respiratory therapists are responsible for airway maintenance. As a joint responsibility at ECU Health, this includes safety and care. If you are unsure how to care for your patient, do not hesitate to ask for help. We are all on the same team. Additionally, ensure suction equipment and setup is readily available for the patient, including suction catheters if needed. Ensure cleaning supplies are readily available for the patient. Remember to ask the patient if they require assistance with their surgical airway care. Some patients are independent at home, but may need assistance in an acute event while they are in the hospital. Safety concerns with surgical airway patients. Most patients with a tracheostomy can speak, and some use a speaking valve, also known as a passenger valve. The patient must have a cuffless tracheostomy tube or have the cuff deflated in order to use the passenger valve safely. If you notice the patient is having signs or symptoms of respiratory distress, please ensure the airway is patent. Provide or implement additional oxygen. Notify respiratory and activate the emergency response team. Tracheostomy management is not a solo sport. Respiratory therapists are central to airway management, but safe trach care requires a coordinated team. Respiratory care, nursing, speech-language pathology, providers, wound care, case management, and receiving facilities all have a role. The American Association of Respiratory Care Adult Tracheostomy Guideline supports tracheostomy teams, protocols, and bundled approaches because trach patients benefit from coordinated and standardized care. The goal is to reduce preventable variation so safety does not depend on who happens to be working that shift. Speech-language pathology should be involved early when a patient is progressing toward cuff deflation, speaking valve use, swallow evaluation, oral intake, or communication goals. Respiratory therapy and nursing partnership is critical for intercannula care, trach care, skin check, securement, cuff pressure check, emergency readiness, and accurate documentation. Case management becomes essential when the patient is leaving our hospital and moving to another care setting. If the receiving team does not understand the tube, backup sizes, emergency plan, suction needs, custom airway issues, speaking valve tolerance, or decannulation risk, the patient becomes vulnerable. The National Tracheostomy Safety Project emphasizes that routine and emergency airway equipment should be available for tracheostomy patients, with most equipment available at the bedside. What is one trach detail you wish you always communicated during handoff? It could be maybe the patient's suction needs or their emergency plan. One missing handoff detail can become the next emergency. Let's pull this together. First, we need to be tube savvy. We need to know the type, the size, and the quirks, and why the tube was selected in the first place. We always need to ask why. Every tube choice, the downsizing step the patient's in, or if the patient's in a speaking valve trial, we should have a clear rationale. Consistency is safety. Bedside equipment, documentation, tube securement, and handoff are not just tasks. They are how we prevent airway emergencies. Also, this is a team effort. Respiratory, nursing, speech-language pathology, providers, case management, and receiving facilities all matter. And finally, policy is our playbook. Guidelines and policies do not replace clinical judgment. They support it. If you can identify the tube, explain why it was placed in the patient in the first place, and recognize when it no longer fits or is no longer in the airway, and communicate the plan clearly, you have met the core objectives for today. The safest clinician is not the one who knows everything from memory. The safest clinician is the one who knows when to verify before acting.